morning, my name is Joanna Sanchez, and today we'll be going over the Emergency Severity Index. Wait times in emergency departments have been increasing due to increased patient volume. Increased ED visits have resulted in overcrowding and increased wait times for minor conditions and even major conditions such as heart attacks. According to the CDC, from 2003 through 2009, mean wait times in U.S. EDs have increased 25%, from 46.5 minutes to 58.1 minutes. The mean wait time increased as annual ED visits increased from 38.8 minutes to 69.8 minutes. With this growing trend, it is vital for emergency departments to implement a standardized triage tool. Research shows that hospitals should implement a standardized triage tool such as the ESI because ESI eases the process of prioritization of patients based on the urgency of treatments and conditions, and the quality of patient care benefits from using a standardized tool such as the ESI. The ESI facilitates reliable prioritization of patients based on their individual conditions. The quality of patient care will benefit from them implementing this standardized ED triage scale. ESI facilitates reliable prioritization of patients based on their individual conditions. According to the Agency for Healthcare and Research Quality, the goal of carrying out the ESI is to accurately capture patients' acuity to enhance the safety of patients in the waiting room by making certain that people with serious conditions do not wait. In order to meet this goal, the triage nurse uses a 5-level triage algorithm. The first nurse assesses the acuity level, and then the patient can move on to different levels of acuity. The acuity is determined by the stability of the patient's vital functions and potential threat to life or limb. Resources are defined as the number of resources the patient is expected to consume in order for their deposition decision to be made by the physician. The algorithm uses 4 decision points, and they are illustrated in this illustration. First, the nurse will ask, is the patient dying, or does the patient need immediate life-threatening interventions now? You can if yes, you can call them a level 1. If no, you should move on to decision point B, where you ask if this is a patient who shouldn't wait. If yes, the patient is considered an ESI level 2 and should be taken into a treatment area immediately. If no, you can ask how many resources is this patient going to need. If they don't need any resources, you can call them a level 5. If they need 1 resource, they are level 4. And if they will need multiple resources, you can go on to decision point D, where you take the patient's vital signs. Depending on the patient's vital signs, they will either be a 2 if they are out of range, or a level 3 if they are normal. The quality of patient care should improve with implementing this ED triage scale. One benefit of the tool is rapid identification of patients that need immediate attention. The focus of the ESI is on quick sorting of patients in the ED using limited resources. The quick sorting of patients can lead to improved flow of patients through the ED and reduce those wait times. For example, patients with ESI levels 1 and 2 should be taken immediately into treatment areas, whereas those with lower levels can safely wait in the waiting room to be seen by a provider. Another benefit of the ESI is the termination of patients which can be seen in less acute areas of the hospital, such as an urgent care unit. For example, many hospitals have implemented policies in which ESI levels 4 and 5 patients can be directed to the urgent care area. The third benefit is that it facilitates communication between professionals. For example, it can be used as a common language for providers to understand what is needed, and a detailed explanation of the patient is not needed. all hospital EDs should implement this triage tool. The ESI facilitates the prioritization based on the urgency of treatment of patients' conditions, and the quality of patient care will benefit using this tool. According to an article by Cummington, the roles of EDs have evolved over the past several decades, from trauma emergency services to people coming to the ED to use it as a primary care facility. The use of ambulatory medical care services in the U.S. has grown 28% from 1995 to 2008. Because of this growing trend, it is important for emergency rooms to implement a tool that will accurately capture patient acuity and improve the safety of patients in the waiting room, and ensuring that only stable patients wait to be seen. Thank you. Do you guys have any questions?
Why are vital signs not used on all levels?
Vital signs aren't needed to determine the patient. If a patient is a level 1 or 2, it is quite obvious if the patient needs life-saving interventions. Only in decision point D are vital signs needed.
Should all patients with chest pain be an ESI level 2?
No, a patient with chest pain can also be a level 1. A level 1 would include anybody that would need something like an IV immediately. If the patient has chest pain and is pale, diaphoretic, bradycardic, stable patients who can wait can be a level 2.